Hello, listeners. It's March 15th, 2020. The situation with the novel coronavirus pandemic has progressed significantly in just the past week. I wanted Inside the Boards to be able to make a contribution towards addressing issues surrounding the whole pandemic. And so we've put a pause on our regular scheduled programming, if you will, in an effort to provide some clinical education on what to look for in patients who have COVID-19 and to provide perspectives from experts and frontline individuals who are preparing or currently dealing with the effects of this pandemic within their local communities and from the perspective of their own specialties. We'll be putting episodes up like this on our medical education podcast, but because there's a bit of a turnaround in those, you can download our mobile application. And before we get time to, edit them really hardcore and put them into podcast episodes, we'll be putting these interviews as they're completed this week into our mobile application on the Inside the Boards playlist that you can find there. This is the first episode where Dr. Ted O'Connell, IETB's Chief Content Officer, interviews Dr. Raj Dasgupta, who has impressive credentials aside from his expertise in pulmonary critical care. Our goal in doing this is to ensure that the information that you're learning about COVID-19 is accurate, combating not only the virus, but the hysteria that may spread along with it. So thank you so much for listening to this. Share this with your friends. And if you have particular questions you'd like addressed in this series, hit me up on Twitter at BoardsInsider. You can email us at info@InsideTheBoards.com, or you can direct message us on pretty much all the social platforms at Inside the Boards. And for you students studying for the USMLE Step 1, we will be launching our Study Smarter series on the Inside the Boards Study Smarter podcast very soon. But this week, we're focusing our efforts on producing content related to the COVID-19 educational initiative that we're attempting. And while this particular episode will go up on all our medical education channels, just besides this one, Inside the Boards has the Physiology by Physio podcast, the Crush Step 1 podcast, USMLE Step 2 Secrets, the original OG Inside the Boards podcast, USMLE Step 1 Success Stories, produced in partnership with Physio, and our Study Smarter podcast, all about question dissections for the boards.
This is Ted O'Connell, your host for today. I think all of you know me, but if you need any additional information about me, you can find it over on my website over at tedxoconnell.com. Today, we have a very special guest who I'll introduce in just a moment. And we're going to be talking about the COVID-19 virus, the novel coronavirus that's causing so much disarray in our world. This is a very rapidly evolving public health issue and topic. So I want to acknowledge that anything we're going to talk about today may certainly change over the coming days, weeks, and months. The COVID-19 virus is affecting people worldwide and is now impacting our local communities here in the United States. This is leading to unprecedented cancellations in sporting events, travel, group gatherings, and education. For medical students, schools are moving online or closing down entirely, and clerkships are being canceled at some schools. So we think it's a really timely topic for discussion. My guest today is Dr. Raj Dasgupta. He completed his internal medicine residency at Michigan State University, Pulmonary and Critical Care Fellowship at Columbia University, St. Luke's and Roosevelt Hospital, and a Sleep Medicine Fellowship at Henry Ford Hospital. Dr. Raj, as he is known, is quadruple board certified in internal medicine, pulmonary, critical care, and sleep medicine. He practices medicine at Keck Medicine of USC's Division of Pulmonary, Critical Care, and Sleep Medicine. He's been featured on multiple media outlets and television shows such as The Doctors and Larry King Now. Dr. Raj travels regularly to teach board review courses for USMLE Steps 1, 2, and 3, as well as the Internal Medicine Board Certification exam. His stated life mission is to educate patients, students, and aspiring doctors for better patient care. To that end, he has published a series of books titled Medicine Morning Report, Beyond the Pearls, and is an editor-in-chief of Elsevier's Clinical Key Student Global Medicine Education Platform. Finally, Dr. Raj has received numerous teaching awards, which is a real testament to his dedication to both patients and the next generation of physicians. So welcome to the podcast, Raj.
Hey, thank you very much, Ted. I'm super honored to be here and to be sharing something together because we both share the same passion when it comes to teaching and educating, and definitely, med students, residents, the public need education about COVID-19.
Absolutely. So we really appreciate you being on the podcast. You have tremendous credentials. Is there anything that I missed that you wanted the audience to know about you?
No, I got to say, if you could actually put a camera on me right now, I'm kind of blushing a little bit, Ted. Thank you for that very extended, long introduction.
Well, it's very, very well deserved. So let's jump into some questions about what's going on in the world today with COVID-19. And I'm going to start just kind of really with the basics. So with COVID-19, what would you say are some of the important symptoms to recognize in a patient who presents to the office or to the emergency department?
Oh, that's a great question, and I'm not going to skirt around it. I'm not going to hide from it, but I wanted to give you, can I go for a little background first, one of my little spiels before we go into that? Is that great?
Absolutely. Yeah,
oh, awesome. One thing I wanted to tell people is that people think coronavirus is brand spanking new, and it's not. People like me and you, Ted, we've known of coronavirus for quite a long time. In fact, since the 1960s, coronavirus has been out there. And when we think about it, it commonly affects humans, and there has been millions of cases of coronavirus, but there are different subtypes, and some of the subtypes actually infect animals. And when we think about these subtypes, I'm going to throw some names out there where other clinicians will be familiar with. There was something called MERS. There was something called SARS. And when we think about SARS, the acute respiratory distress syndrome, this was around 2003. This was a type of coronavirus. And in fact, it's going to be when we have these coronaviruses that infect animals, they mutate a little bit, and then they infect humans, and these are the deadly ones. And that's what SARS is, and that's what this COVID-19 is. And in fact, the other name for COVID-19 is SARS-2. So because it's very similar. So it is unfortunate that, we have COVID-19 and what's going on right now. But coronavirus as the name, it's been around for quite some time. But to go back to your question, because everyone asked me about that, is that who's duking out for supremacy right now? It is influenza virus and coronavirus. And if you put them next to each other, at least in my opinion, I can't tell you who has coronavirus and who has the flu. And when we talk about the symptoms, beyond my clinical experience, in the last couple of weeks, a lot came from an article where they were actually, describing the symptoms of the individuals who were in China where it first broke out. And they actually kind of said what percent of the symptoms they were having. So common symptoms that you would think about would be fevers. And when we talk about these fevers, they're going to be fevers of 103, 104, and they could happen out of nowhere, just like the flu, just like a boom, Mack truck just hit you. And, prior to these fevers happening, some of these patients could be 100% asymptomatic. And I can't say that enough, is that because people can be asymptomatic, that's what's causing, some of this panic, because you never know who has it. On top of that, you're going to get lower respiratory tract symptoms. So you could have shortness of breath, speaking medical words, dyspnea on exertion. You could definitely have the cough, but when they were kind of looking at the symptoms from an upper respiratory tract, the kind of, I have a sore throat, I have a runny nose, some rhinitis, they didn't really see much of that. So just like, when we always talk to our patients, Ted, and say, did it sound like you got hit by a Mack truck and that's influenza? That's kind of like coronavirus too. But every time I want to give my opinion or my statement about coronavirus, I always got to watch what I say because things are changing all the time. It's impossible to have an interview anywhere without having your laptop open because something new will just pop up. So right before I knew I was coming on here to talk to you, they were focusing on the GI symptoms. So that was kind of interesting. So it's not a very common symptom, but some people stated that they had some loose bowel movements, some diarrhea prior to getting coronavirus. So now the thought process is, when it comes to transmission, of course, we are all like, hey, it's all about respiratory droplets. Now the hot topic is, could it be exchanged fecal oral? And I just hate saying the word fecal oral because that's gross to begin with. But, maybe there's more ways of transmission than we think. So this kind of goes back to, since it's a big mimicker when we talk about other viruses, specifically influenza, the answer is we need the testing if you really want to know who is who and what's what. And this comes back to, and I don't know why I'm on this little ranting spiel right now, where I told some patients and some other interviews I did that I'm sure there's people out there that actually regret not getting the influenza vaccine. Because right now, if you present to me while testing is so scarce and say I have these symptoms, if I knew or know you had the influenza vaccine, chances are that you may have more of a risk for coronavirus. So that's my little spiel about the symptoms and how they're very similar to influenza.
Wow, Raj, you're really demonstrating your skill as a teacher already.
Thanks.
So related to the influenza vaccine, like me, are you currently advising people who have not gotten their flu vaccine to go ahead and try to get it?
I 100% agree. When we talk about the influenza vaccine, I think you, Ted, and me, we all have those patients that just swear something horrible happened from the influenza vaccine. I have an egg allergy. I don't want Guillain-Barré. I don't wish those things to anyone, but there are people who just don't believe in it. And I'm sure me and you have heard this all the time. The last time I got the flu vaccine, it gave me the flu, and I think a lot of people are regretting those statements now. And what the scary part is that when we talk about getting the flu vaccine now, I agree, because that's one less thing to worry about. Because if someone doesn't like you out there, in theory, is it possible you can get the coronavirus, COVID-19, and get influenza? The answer is yeah. I mean, there haven't been a lot of cases of that. We're not going to make it up, but it's possible. So what you need to do is take those risk factors away, things that you can control. You're not going to control the whole society, using Purell to wipe their hands and everything, but you can control yourself getting the influenza vaccine. If you're having fevers, if you're not feeling well, that's not the time for you. But I definitely 100% agree about that.
Okay, yeah, great. And while we're on that topic, I guess the same would hold true for pneumococcal vaccines and really just trying to protect our patients from anything else that could constitute a hit to their system, right?
Oh, yeah. And and people ask, and I'm sure we're going to talk about this even more, like, well, how do I die from coronavirus? It's just like any other virus that we know that, once again, let me refer to influenza, which we have much more data on. Very few people will die from the influenza virus. It's that superimposed bacterial pneumonia. And that's what we've seen so far, looking at the data of people who unfortunately passed away or are very ill or in the ICU. So when we talk about, I always love the word common things are common. If you're going to catch a pneumonia in the community, that's where I'm assuming it's not going to be Pseudomonas. It's not going to be Klebsiella. It's going to be strep pneumo number 1, 2, 3, 4, 5. So I love how you already threw the bone out there to say, hey, if it's indicated, you should get your pneumococcal vaccine. Problem is, I think it got a little confusing with pneumococcal, and I'm sure you could, like, being family practice, you could, kind of get my back on this. Now that we have the 23 and the 13, one's called the Prevnar, one's the Pneumovax, people are getting confused kind of what to do, and the big thing is that, if, let's say, you have no respiratory illnesses or comorbidities to begin with, usually you're going to get the Pneumovax around 60 years of age, Pneumovax, which is a 23 valent, and you repeat it in 5 years, and that'll be around 65. We have the 13 called the Prevnar, and I hate using brand names. It's very un-university of me, but in the Prevnar, it actually covers more of the serious deadly serotypes out there. And people don't realize, hey, it's no problem if you've already got the 23 to get the 13. If you already got one of the 23, you could go ahead and get the 13 next. It's not a big deal. So, but if you have comorbidities, meaning that you have any respiratory illnesses, you should get them right away. That includes asthma, COPD, bronchiectasis, people with interstitial lung diseases, kind of rattling off a lot of these, pulmonary things I think about. But you're right, Ted. If you want to protect yourself, the the influenza virus vaccine yearly, and definitely the pneumococcals. That's things that you could control.
That's great, Raj. Yeah. So let's talk a little bit about distinguishing COVID-19 from other illnesses. You already dove into it a little bit with some of the symptoms and even perhaps the GI piece. But and I know that you are working on the wards and in the ICU and aren't necessarily seeing these patients come to the office or the emergency department. But if you were in that setting and you have somebody coming in with either upper respiratory or lower respiratory symptoms in these early stages before we have like really good access to testing, and you're really having to take a clinical diagnosis without those tests, how would you suggest sorting these people out? Like cold, URIs, pneumonias, even allergies. Like what's going to, for the medical students that are listening to this, how would you suggest that they really think about this to sort these patients out?
Sure. I think times have changed quite a bit. We really rely on the patients of being good historians, which is a tough, big burden on the patient itself. And we know a lot of patients are not the greatest historians, and pieces of information that are not important to them are important to us. So number one, I think that for once, I'm going to say I am now a big fan of protocols. Being a critical care doctor, I never really loved having to do a checkbox of things to do. But that's where I felt that, a lot of hospitals, the United States in general, were a little behind the eight ball because we didn't have those protocols set. Because, I don't want to skirt over what you said in your question, which was very important. If someone suspects that they have, coronavirus, COVID-19, it's not as simple as going to your primary care physician, because of the fact that they may not be prepared to take those samples to rule it out, because they got to protect themselves in their office. They need special masks to do it, and also it's not as simple as telling these patients, go to the ER. That's the last thing you want people to do, is to flood the ER, ruling out COVID-19.
Right.
So that's where, it's, I don't want to switch this from a great medical talk to a political talk, but, the big thing is what we need are testing centers. And I never really realized that, because USC is really doing a great job now about coordinating with Department of Health, coordinating with the CDC, and we're trying to set up these testing areas. One set up at Cedars-Sinai, one set up at UCLA, one's at UC San Diego, and we're really trying to get ours set up because that's what you need. Because people don't realize is that once you get tested, it's not only just getting tested. Right now, it takes 3 to 5 days to get results. And where are these people going to go? And who's going to give them the follow-up? So I think that there's so many things, but if you come, and we have protocols now about, your level of suspicion, how bad do you suspect it? And things actually are different now. And I hate being scary because I'm like the most positive person. But, before it used to be like, do you have a travel history? Do you have 3 degrees of separation? Do you have a no contact? But right now, COVID-19 is in the community where people are just getting sporadic cases. And that's why, sure, we're all going to isolate ourselves now, social isolation. But we should have done that super duper duper long time ago. And now it's already in the community and it is going to spread no matter what. What we're trying to do is, slow down the rate of transmission. But the sad thing is we don't even know if we're doing that because we don't have any testing kits to find out if we're slowing the rate of transmission. Right. But when we talk about, this happened already, we had a lot of cases of rule out coronavirus, is that, you get the history and common things are common. I think I said that for the 1,000th time, you want to make sure that could it just be influenza? Let's just screen that out right away. Can it be an upper respiratory tract infection that we see commonly? Adults can get RSV, adults can get adenovirus. So we do have a respiratory panel that we order. I think the big thing is that anytime right now that's going to be on your differential diagnosis, anytime we're going to have appropriate isolation. And we do have isolation rooms. We do have, certain protocols in place of how do we test these patients? When do we test these patients? But I think it's going to be really about that medical student staffing that case with the intern to the resident to the attending to say, hey, is this something I'm really worried about? And the problem right now is that if you keep on watching all these, news reports on TV and webcasts, and oh my God, everything starts off with the word alert, sudden update, and you're so panicked. Everyone's in panic mode now that the minute you even think it may be COVID-19, you're going to rule it out. And probably everyone listening to our podcast probably thinks they have COVID-19 because of all these symptoms. So it's hard. And, the easiest way to test for it, testing, I'm not saying we have the test kits available. I'm just saying it's really just a nasal oral swab. And you could send it to here in LA, like, Quest Labs, they can do it. But the question is, how long does it take for the turnaround? Where is that patient going to be? Should they self-isolate? Should we admit them to the hospital? There's really a lot of questions out there. So the answer is we don't have good answers. But if it's on your differential, and they're in the hospital right in front of you, definitely contact someone of higher authority. If you're a med student, you're intern. If you're an intern, you're attending. And we all have our emergency contacts. We have our direct contacts to the infectious disease doctors, and they're just super duper amazing. And we should give a big shout out to everyone, especially my ID doctors that are like not sleeping anymore because they're so stressed. But we have protocols that they help us execute to make sure we treat these patients correctly.
Yeah, I can't emphasize that enough, the shout out that we need to give to infectious disease. They really are carrying a heavy burden these days.
Yep.
So you touched a little bit on a question I wanted to ask you too. You mentioned isolation rooms, and I would love to hear kind of what the critical care community is saying about this, how you're preparing, even the potential for what happened in Italy with with hospital systems getting overwhelmed. So what's going on in your intensive care units and your ICU community?
Yeah, no, it's very scary. And the answer is it's not just scary because of COVID-19 coming in. Every time you suspect a case, every time you want to, quote, rule it out, someone else can't get that ICU bed, and in a non-mean way, we definitely have COPD exacerbation. We have people with interstitial lung diseases. We have a cystic fibrosis, center of excellence here at USC. And, those rooms, those ICU rooms will be taken up. So people can't only think about the COVID patients themselves, but who's not getting that bed. And, it's going to come to the point where we may have to start sharing. I know it kind of sends chills up my spine, sharing these ICU rooms. And then it becomes, not being selfish and only thinking about myself and my team. But what about the nurses out there? It's all about nursing staff being comfortable, nursing staff getting good training. And it's so easy for me, to say, hey, let's execute this protocol right here. But a lot of the protocols entail my respiratory therapist to go in the room with appropriate gowning, with active ventilation systems attached to their suits to do these things. And, a lot of us weren't ready, prepared, or even thought this was going to happen. No, and sometimes when we have certain patients that come here, it looks like that movie Outbreak from the olden days. It is really scary.
Yes, we're living through really interesting times.
Yeah.
Are you guys seeing already cases of COVID-19 at your medical center? On the wards in the ICUs? And I don't know if this is something you can talk about or not.
No, and it's actually really, really public knowledge. I think at this point, there can't be any secrets, about different hospitals. And I think our CDC representatives are doing such a good job. And you know how it is on your phone. Your hospital sends you updates every second. It's my phone is literally blowing up with emails. But the answer is we have not had a confirmed case of COVID-19 at USC Keck Medical Center. There's been rumors that there may have been one at County, but I can't confirm that at this point right now. Definitely my neighboring hospitals around Southern California have had cases. And, I always tell people, my big thing is I don't want individuals to panic. If you could tell me if I could tell everyone what I'm all about, it's about being prepared. I'm all about that, but not being panicked. And I think that it's really easy that every time, once again, you turn on the news and it starts off with this word alert, and you're like, oh my God, what's going down? And it's going to say another case. And it's like, no, duh, there's going to be another case. If you're going to be testing more people, there are going to be more cases, So I think that you always have to take everything in what context are they saying that? And the reason why I'm making a big stink about this is because, many people, when you read on the internet, I don't even know if I could call it the internet anymore, but you read a website or, you listen to a podcast and they say, COVID-19 is 10 times more deadly than influenza. And you got to get the numbers because people only hear the word 10 times. But, talking to some of my ID buddies over here, the mortality rate for influenza is around 0.1%, which is good. It's not the greatest. People still die from it because it's 0.1% of what total number. But if you talk about 10 times 0.1, that's a 1% mortality. So it may not be the number, the way it flashes on the screen and makes everyone panic, but it's good to understand these things and be aware that it is good we're discovering more cases to an extent, because then we know who to isolate and who needs to actually be wearing masks and not be wearing masks. So remember, take everything for face value.
Right. And even that mortality rate number is certainly going to evolve over time, because right now the patients who are getting tested are likely the ones that are the most critically ill, and not all comers out in the community, right? So that we're testing the ones who are most ill, that are more likely to have mortality associated with their illness. So it will probably skew downward as time goes on.
I agree. And we should tell one of our other themes for today's podcast should be not everyone needs to get tested. And that's hard with all the panic going on out there. But yeah, if you have comorbidities, you're immunosuppressed, you're on steroids, you have HIV, I mean, definitely these are the people that need to be tested.
Great. I want to pick your brain a little bit as an intensivist here, Raj, and kind of do some teaching for the students who are listening to the podcast.
Sure.
So a patient who actually has coronavirus and is significantly ill from that and hospitalized. You mentioned earlier it's the secondary bacterial pneumonias that are a real issue. Can you talk about that, and also about ARDS and kind of what's being seen around the world with those who are getting critically ill with coronavirus?
When we talk about how does a pulmonologist like me get involved or feel passionate about COVID-19, it's because of the lungs. And like we both said, that is going to be the organ that causes all those problems. So I would say that having a superimposed bacterial infection, the way I look at it is that virus does a damage in your lungs, makes your immune system weak, and it just is a setup for a bacteria to come in there. And I mentioned the word community acquired. So when we talk about pneumonias, there are many different ways you could categorize them. People say typical and atypical. Some people say community acquired or hospital acquired. And those are all correct statements. But because most of our patients will be coming from the community, we think about a community acquired pneumonias. And I always think about the big three. Number one is always going to be strep pneumo. And for my med students out there, you love to hear buzzwords like rust-colored sputum. When you look under the Yagras, look at these lancet-shaped diplococci. So think about those type of things. You could diagnose strep pneumo with a urinary antigen, even though it's not that common to use, but you always want to culture to get sensitivities. Number two is always going to be Haemophilus influenza, the bacteria. And number three, I don't see a lot of it. It could be Moxarella catarrhalis. I see that more when I think about COPD patients. But of course, when you think about hospital-acquired pneumonias, because some people could be in a nursing home or a long-term facility, well, then you worry about some nasty, nasty gram-negative bugs like Pseudomonas, or resistant bugs that we call Staph aureus, like methicillin-resistant Staph aureus, MRSA. Regardless of these bacteria or no bacteria, people with COVID-19 may go on to develop something called ARDS, which you said appropriately, and that stands for Adult Respiratory Distress Syndrome, and that is horrendous. So when we think about ARDS, I don't think there's enough time in this podcast to actually give you all the gruesome details or the awesome teaching about it, but it's going to be a lung inflammatory syndrome where these wonderful, juicy, plump alveoli get filled with this inflammatory fluid. And you can imagine these alveoli they shrink up, they get shriveled up, you know what I mean? So you can imagine if your alveoli are shriveled up, they lose surface area, you can't diffuse oxygen in well. And if these alveoli are filled with this inflammatory exudate, that's another thing preventing CO2 from getting blown off and oxygen from coming in. And not to mention, your lungs are just very, very non-compliant. And for my step one listeners, what is compliance? That's always going to be about pressure and volume. So if you're going to be non-compliant, you need lots and lots of pressure for just a small little change in volume. And because of that, it's really hard to blow off CO2. They become hypercapnic. They have their alveoli are actually filled with inflammatory fluid and shrunken up. So they're very hypoxic. And there are very special ways that we have to ventilate them, meaning that, number one, anytime you have ARDS, you always get managed on the ventilator. We don't use non-invasive BiPAP or CPAP for these patients. They're in the ICU on the ventilator. And of course, you want to treat the underlying cause, and that could be giving antibiotics, or if it's just the virus, kind of like waiting it out with supportive care. But I would say the teaching point, if there is one thing I could say that helps decrease mortality for ARDS on the ventilator, is that we use low tidal volumes. And what does that mean? It means that if we give normal tidal volumes that maybe me or Ted would use when we're breathing, they would all go to the good alveoli, because there's still some good alveoli left in the lungs, and they would rupture. So we give lower tidal volumes to protect the remaining good alveoli. And there are some, physiological consequences of doing this, but studies have shown, and a classic study is the ARDS trial, the alveoli trial, that showed that low tidal volumes will help out more, improve survival. Here's where it kicks in. Do we have enough ICU beds? Do we have enough ICU ventilators to help all these patients who may come in with coronavirus, as well as our other usual patients that come in? And ARDS, like I said, it's a law of supportive care. And I wanted to mention one really interesting statement. So for ARDS, a spicy topic is about giving steroids. And some studies have shown, give some steroids for ARDS, and other studies, maybe not so. If you do give steroids, you want to give it earlier in ARDS, because it's a spectrum disease that starts off with more of a, exudative phase where maybe there's some active inflammation where steroids could work. And if it progresses, it goes to more of a fibrotic phase where you do nothing. And why am I bringing this up is because the WHO and the CDC stated that if you just have coronavirus, there's no role for steroids. And that was a statement that was made. And I think that's important because, if med students are watching doctors like me in the ICU, they probably get the impression I give everyone steroids because, it seems like no one leaves anyone's ICU without getting a dose of steroids. And that's really been a big controversial issue in the ICU, is that, well, what are we going to do if someone with coronavirus comes in and they have ARDS? What's going to be the most important thing to do? Is give the steroids for the ARDS? Or are we giving it for the coronavirus? But data clearly has shown for coronavirus itself, do not give steroids. And that's the take-home message.
That's a great learning point, Raj. And actually, I think you've kind of set this up for, if you don't mind doing a little bit more teaching for the students listening here, could we dive into ventilators even a little bit? Talking
Sure.
about criteria for putting somebody on a ventilator, how they work, basic settings, criteria for discontinuing ventilation. Wherever you want to go with that, I think could be really helpful. I think sometimes ventilators are a little bit of a kind of a black box for students.
Here's the thing, is that number one, I definitely think we should do another seg on ventilators, because now you're getting me super fired up and we could do one. But let me give you the basics, is that, when do you want to put someone on the ventilator? I think that when we think about positive pressure ventilation, which is actually the broader step one topic, because right now, me and Ted, we're breathing through negative pressure ventilation. When you put someone on positive pressure ventilation, there are two main types, non-invasive and invasive. And non-invasive are things like CPAP, which you guys probably think about sleep apnea quite a bit, or BiPAP, bilevel positive airway pressure. But that's giving positive pressure through a mask. And sometimes it's nice to use that because people don't want to have a tube through their vocal cords into their trachea for a bunch of reasons. But the other type is invasive, and that's what we're talking about when we talk about ARDS. I need to put you on the ventilator itself. And, I think the take-home message for this quick talk is there is no set criteria. We don't intubate someone based upon an arterial blood gas. That's not the answer. You have to look at the broader picture. What is their mental status? Am I doing it for hypoxic respiratory failure? Am I doing it for hypercapnic respiratory failure? Am I doing it for the work of breathing? And all these things are definitely going to be factoring in when we think about doing it. And once I put them on the ventilator, well, here's where it gets a little tricky. It's kind of like, what mode do you want to pick, And I think that in broad strokes is that there are two broad modes. Number one, there is the Flintstones mode of ventilator called CMV, controlled mechanical ventilation, meaning that the ventilator controls everything. So if I want to breathe 14 breaths per minute, and I put 14, that's what you get. I can't breathe 16. I can't breathe 18. The ventilator controls everything. Now we use what's something called assist controlled mechanical ventilation, ACMV, assist controlled, meaning that, hey, let's kind of let the patient have some of the control here. So all the patient needs to do is trigger the vent in order to get a breath. So that's the new standard, assist controlled mechanical ventilation. And of course, there are different types, below that. And once again, I don't want to bore anyone out there. Trust me. So let me just say that the two broad modes are going to be a volume controlled mode and a pressure controlled mode. Because when we talk about ventilating, it's all about my favorite C word in the whole world, which is compliance. So what happens is that if I choose a volume control mode, that means I'm in control of the volumes. What's going to be the limiting thing is going to be the pressures. So if let's say I use a volume control mode, I always think about 4 things that I need to pick. Number 1, I always think about what's going to be my FiO2. And if someone gets intubated, you give them 100% right off the bat, and then maybe turn that down a little bit. I always pick a respiratory rate. If it's someone with ARDS, we tend to pick a higher respiratory rate right away. And you're going to ask me, why, Dr. Raj? Is because my tidal volume is going to be low. If I'm giving a low tidal volume, I try to make up a little bit for that by giving a higher respiratory rate, because tidal volume times respiratory rate is minute ventilation. And the last thing I pick is something called PEEP, positive end expiratory pressure, which is a button on the vent, on the vent, which is kind of like when you're breathing out. Imagine you breathing out through a tube, and at the end of expiration, you can imagine a valve shutting, and you breathe against a closed valve, like, and what happens? Pressure will back up and open up these alveoli. So there's volume, where I pick the volume. The other one's called pressure-controlled ventilation, and as it implies, I don't get to pick the volume. I get to choose the pressures, how much pressure I need to push in the air. And what will be the variable will be varying volumes. And sometimes I pick pressure control because I want to be in control of the pressures, because I don't want to drive them up too much. And of course, once again, I pick the big 4. What's my FiO2? Probably 100%. What's my respiratory rate? Probably a little bit on the faster side, maybe 18 to 20 breaths per minute. And of course, the tidal volumes are going to be varying. And I could always set my PEEP. And, when we talk about what's my number for PEEP, well, how hypoxic are you? Usually I start off with 5, but that number could go up to 10 to 15. And of course, I just can't take my PEEP button and crank it up as high as I want. Well, that will cause some barotrauma, and I'll probably get a lawsuit. So we have to actually titrate the PEEP to these parameters called peak and plateau pressures.
Do you mind if I ask you a couple of questions that are a little bit less medical and maybe a little bit more social around this COVID-19 situation?
Of course.
One is I'd like to hear, what are responsible ways for media personalities like yourself in medicine, and even media personalities outside of medicine, to help address this pandemic?
When just yesterday, I was actually at Entertainment in Hollywood. They're on Universal Studios. I felt so celebrity-like being there, and it was on a show called Pop News. And I really liked it for one reason, is that they wanted to be positive. And I think that, when you're going on the news, whether it be a website or Instagram, this podcast, or on TV, is that you have to be honest and try to give accurate information. And I told them, I said, when I go on the air, I don't think the questions I want are going to be statistical questions, because I'll put my foot in my mouth, because things are changing all the time. And I think that always trying to be honest, I think that my theme for coronavirus is not going to change. I want to be prepared, but I don't want people to panic. And, for those who listen to the whole podcast, it's really easy that when you watch a lot of those news platforms, alert, they're in bright red and they give you numbers and everyone just panics, and that's why there's a freaking toilet paper shortage out there, Yeah. And so I think that there's always that fine line. So if you ever get a chance to watch this, my episode on Pop News on E, it was very jovial, and it was nice to show that I wanted people to realize that, hey, this is a tough time in our country. I know, and I think that we need to stand together. And I do really, really, really appreciate NBA, NFL, all these athletes doing the right thing because of, I feel that they're role models. And I think that all the things we're doing right now to help out with COVID-19 is not because, I'm going to tell you, Ted, you're never going to die from COVID-19 and neither am I. But my mom and dad might, and we're doing it for our elderly generations. And that is a lot of responsibility. And I think that young kids look to the LeBron James, to see if he's doing the right thing. And it's nice that they are doing it because they're going to be setting the bar for being a good influence. Because all we could do now is to do things that are in our control, which is the social isolation. People still need to go to work. I'm doing this podcast from work, that's just the way it is. There's only so much you can do. So I think that being honest, trying to be up to date and trying to be positive, that's what people need to hear.
Yeah, that's a great message and dovetails nicely with my next question, which is how can the media contribute to combating the pandemic? And on the flip side, what can hurt the efforts around controlling and helping to treat the situation?
Yeah, I think the limiting factor, and it's going to be, everyone's going to nod their head and say, I've heard that 1,000 times, is the amount of testing kits, and I think that every time I watch a news update, apparently there should be 1 billion kits circulating somewhere that I haven't really seen, and people don't understand why that's the problem. It's the problem because that when the first outbreak occurred in the United States, I believe it was in Washington, it happened in a nursing home, but surprise, surprise, it affects the elderly. And at that time, if we had the testing kits, it would have been great that anyone who was in contact, boom, gets screened. We know who to isolate. But we didn't have the kits at the time, and these people were just out and about. And so now that we're, when we talk about, hey, what is the mortality? Are we improving from day to day or getting worse? All these things are based upon mathematics and having a denominator of how many cases do we have. So when you ask me what's the mortality rate, it's the number of cases based upon number of deaths based upon number of cases. And because of the lack of kits in the United States, we never have an accurate denominator, talking about the disease itself or comparing it to someone else. And when people always ask me, hey, Dr. Raj, how do we know when we're doing all this social isolation, it's going to be working? Well, that's going to be when we know that the incidence of new cases are decreasing, every day and every day. But the problem is, if you don't have the testing, how do you know you're having a decreased number of cases? So that's why everyone always has that question mark. Everyone says the word usually, everyone says the word hopefully. But I think that the same things, the same standards I hold myself to, I hope other journalists and media experts do the same. And I guess the one tip I would give is that if you're going to be giving medical information to anyone, I hope whoever it is has a doctor present. Because I think that you need that doctor to validate, to agree with what's being said. I don't think it's fair that only a publicist or newscaster should make such strong statements, because it does raise a lot of panic.
That's a great point, Raj. I agree 100%. So our audience on this podcast is primarily medical students. Do you have thoughts on how medical students can help during this pandemic, especially as we're seeing classes get canceled and schools trying to do online stuff, and even clerkships and rotations get canceled? How can students potentially contribute here?
Oh, that's, what? I'm going to give a shout out to some of my favorite medical students in the whole world. It's the University of California, Riverside. You didn't see that coming. So I'm also an assistant professor at UCR, and I just actually did a preparing for residency to the fourth year medical students. And, I go there almost every year. And in the prior years, I'm telling you that, Ted, the class was packed. This year, it was just 4 people, 5 people, because they were showing responsibility. And they're like, Raj, we dig you the most, but there's something going on, and we're just going to telecast this, and everyone's watching at home. Only the students that needed to be there for other reasons really showed up. And I loved it. I wasn't bummed out at all. I was still just as pumped up to give my lecture. And it really impressed me about that. It impressed me that, if there wasn't a necessity to do a rotation, they were very open to say, hey, maybe I don't need to be in the campus at this time. I don't need to be in the hospital at this time. But the students, I also hear the flip side that were like, hey, I want to be a doctor, and my job as a doctor is to be in that hospital. So if I need to be there and they feel I need to be there, they were willing to actually do their rotation. So I think the fact that they were looking towards their mentors and their directors of what's the best thing to do. And they were open to suggestion. I think it was great. And another thing that I just want to say is that, for anyone, not just medical students, little things go a long way. And I think that, teleconferencing my patients for care, if they don't need to come see me in the office, I'm finally saying, all right, let's do this teleconferencing thing. And I think it worked out really, really well. My wife and I, we love to go out and go to restaurants, but instead, we still want to support our favorite restaurants. We call them for delivery. So there's a lot of things that everyone could do that I think is just very reasonable. So, if I had to take a guess, who's going to probably make a killing from this stuff? It's probably going to be like Disney Plus and Netflix, because everyone's going to be at home watching TV and movies,
All right, everybody, you heard that there. There's the stock picks for the week from Dr. Raj. How do you see this, Raj, affecting medical education with coursework, rotations potentially getting put on pause right before match week too, right? So, and it may even delay how the current third years finish up their core clerkships. Have you thought about this and how it might affect education? I just heard the discussion you did about Step 1, USMLE Step 1 going to pass fail. So I'm sure you've kind of given this other situation some thought too.
Sure. I think that number one is that we all have a sense of responsibility, and I'm pretty sure, and LeBron James isn't happy that, the season's on hold with him on the cusp of winning a championship. Same thing when I think about my medical students, their passion is becoming the best doctor. But you know what? There's a higher priority at this time. And that's going to be being a role model. That's going to be protecting people who are going to be at the highest risk, which is our parents, people older in age. And I think that's the job of the doctor too, is to show compassion and good judgment. And that's where, sometimes it's easy to do shortcuts. It's easy for me when I'm in the hospital to not wash my hands or to high five and touch people. And I always say to myself, it's beyond me. It's me trying to be a good role model for everyone else, because how can I go on TV or talk on this podcast if I don't do things myself? So I really think that it is a sacrifice. It stinks. And I think that I could even ask anyone out there, how has it affected them? It really has. People want to go on trips. People deserve vacations. People have loved ones who are sick in other states. And, I think that, the students I've interacted with, so far have only impressed me in the sense that they're like, Dr. Raj, there's a bigger picture here, and they're really being good sports about it. And honestly, more people are worried about Step 1 being pass or fail when it comes to medicine versus how's the coronavirus going to affect it. That's my take.
Right. Well, you've got a great approach to all of this.
Yeah.
I heard you mention LeBron James. If I'm remembering right, you're a big Laker fan, just like I am.
Yeah, I had the tears, and this has been just a disaster of a year for the Lakers between Kobe Bryant and now the coronavirus. But you know what? Our time will come soon.
I certainly hope so. I think one thing that we need to all remember here too is there are a lot of people who are working paycheck to paycheck and really don't have the give in their financial situation and can really be affected by this COVID-19 situation and schools being shut down and needing to find childcare. And as you mentioned, the restaurants are potentially affected too, as fewer people go out to eat, and it's going to affect movie theaters and all kinds of different things. You live somewhere over in LA, right on the east side? Is that?
I do. I don't live in really close to Pasadena. I live in a place called La Cañada, and it sounds really fancy, but it's just spelled La Canada, but it doesn't sound sexy when you call it La Canada.
Yeah. So I want to give you a chance, since the restaurants and all kinds of small businesses are potentially going to be really affected by this. Yeah. Any favorite restaurants that you want to give a shout out to, just to kind of help support them through this situation?
Oh my God. There's a pizza place right by my house. It's called Hello Pizza, and it's owned by this it's an Asian restaurant, but they make like American pizza with like an Asian feel to it. and it's so tasty, and it just stinks that they're a mom and pop place. And when I call them up, they're like, because they're new, because it's small, they know your name. They're like, Raj, is it you? What do we want? So, hello, pizza. I wish you all the best. We're still ordering your food. I'll probably order it tonight when I get home. Okay.
That's great. And let them know that you gave them a shout out on the podcast.
I will
help their
I
business a little
will.
bit.
Yeah.
So Raj, as we wind down here, are there any other messages you want to put out there, or any other thoughts about COVID-19 or even teaching topics that you think students need to hear?
I would say one of my favorite little tidbits before I say goodbye is that, people have always asked me, why is it called, coronavirus? And I just want everyone to know for sure that it's not because it's named after drinking a beer under a palm tree, okay? That's not why it's coronavirus. It's called coronavirus is because when you look under the microscope, it actually looks like a crown. That's what, corona means. And it has little spikes on it. I'm sure all of us have seen this when we see these newscasts. They put the little, chyron up there about coronavirus. But I think, everyone, once again, I love being redundant. Repetition is key in teaching, is that, be prepared. There's no harm in being prepared, but please don't be panicked. And the last P that I always want to mention is be positive. And that's why I'm always smiling. If you ever look at me on my social media, I always think that see the good in people and the good in things. And I know that, as a country, we're going to survive. And before I forget, the last thing I want to say is I want to give a shout out to everyone who is working hard to help with coronavirus around the world. And I want to give a sincere that I hope everyone who's infected or have loved ones infected, I wish you the best medical course.
Your messaging is just absolutely great, Raj. I want to thank you for taking the time out of your busy day to join us on this podcast. I think students are going to find this to be super helpful. I hope that at some point in the near future, we can have you back and talk about ventilators and even pick your brain on other topics, since it's just such a wealth of knowledge. So thank you very much for joining us.
Oh, you're super welcome. And I'm going to take you up on that, Ted. We're going to come back. We're going to talk about those ventilators.
Awesome. All right, Raj, we'll have a great rest of your day. Okay.
You too, buddy.
All right. Take care.